Good afternoon to everyone. Good afternoon to the colleagues sitting here and the colleagues online. And it gives me a great pleasure to introduce today the Gairdner speaker who came to our university. And she is Dr. Elizabeth Eisenhauer, a very, very eminent oncologist, clinical trialist. Dr. Eisenhauer is a professor emerita at Queen's University College, and even following her retirement, she's been incredibly active as one of the most eminent cancer researcher and clinical trialist in Canada and internationally. Suffice to say that behind her belt, so to speak, there's more 170 trials she led, 170 cancer clinical trials she led. And through her tireless work, the way how we treat the patients across the world, the patient with melanoma, the patient with breast cancer and other malignancy hasn't changed when it comes to the pharmacology and clinical pharmacology of Taxols, paclitaxel, and other compounds. And she's been very widely recognized across our nation and outside. And the latest sign of this great recognition is the Gairdner-Whitman Award. As you probably know, this award is given to exceptional leaders of science who also have the amazing own research program. And this is why Elizabeth received this award in 2021. In addition, she's got all the biggest awards you can think of being a scientist in this country, including Royal Society Fellowship, or she's also the officer of the Order of Canada. It will probably not be enough at the top of this lecture to list all the awards that Elizabeth has accomplished and all her accomplishments during the time. She also is incredibly nice. She came to Saskatchewan. She had 2 sessions with our high school students and the wonderful talks about her own career, attracted lots of questions and lot of interest. Suffice to say that the number of students said, I want to be a doctor, I want to be the neurosurgeon, I want to be pharmacologists. Okay, guys, even some people want to be pharmacologists. So with this one, once again, Elizabeth, thank you very much for coming to Saskatoon. And the floor is yours with the incredibly provocative title, Seeking the Cure for Decades of Cancer Clinical Trials in Canada.
Thank you very much for that very warm and kind welcome. And to those of you here in person and online, I look forward to the next, 35 minutes of me talking and 25 minutes of us conversing. So I have no disclosures or conflicts of interest. And this is an outline of what I'm going to cover. Mostly, I want to just take a little bit of a chronological journey through my cancer research story. But before I begin, I wanted to say a few words about Saskatoon. So Saskatoon is, and especially the University of Saskatchewan, is rather woven into my personal family history. In 1957, my grandfather, Earl Eli Eisenhauer, who was Deputy Minister of Public Works in the province, received an honorary doctorate of laws from the University of Saskatchewan for, amongst other achievements, his work in providing beautiful and well-planned buildings for his alma mater. He graduated in 1915 in agriculture from the University of Saskatchewan. My parents were both University of Saskatchewan graduates in 1948 and 9. You can see, this is probably midsummer, I think, in this photograph, with all that nice snow. And then my younger sister, Carla, was a family physician, a director of the Saskatoon Community Clinic, and a teacher of undergraduate students here until her early death from glioblastoma in 2010. So a lot of nice historical and familial reasons to love the prairies and love this town. So let me start back with the story of cancer treatment going back well before I was born, to the first interventions that showed any benefit, and they were surgery and eventually radiation. Surgery was only possible after anesthesia and sterilization techniques were developed in the 19th century. And although radiation was also discovered at the end of that century, it wasn't until many years later when safe dosing and other procedures were in place to use it. Many patients therefore died within months to years of their diagnosis, and that had been the case for hundreds or even thousands of years going back in time. In 1947, the Canadian Cancer Society created the National Cancer Institute of Canada as its research arm. And at that time, 5-year survival rates for all cancers was only about 33%. Between the 40s to 80s, some changes started to emerge. Firstly, therapeutic radiation became possible. And as I hope you know, Saskatchewan was one of the very first places in North America to deliver therapeutic radiation to cancer patients. New imaging technologies, CT scanners, made it possible to stage cancers better and thus to plan appropriately local regional therapy with surgery and radiation. And the first so-called chemotherapy drugs had been discovered and were being moved into the clinic, many of them through the US National Cancer Institute Drug Discovery Program. And these included alkylating agents, which were nitrogen mustard derivatives, plant alkaloids, such as vincristine from the periwinkle shown there, and anti-tumor antibiotics. In the 1980s, which is when I started my research career, the 5-year net survivals for common cancers are shown on the right of this slide, with all of them highlighted under 50%, with the exception of breast cancer at 70%. And I'll ask you to kind of keep those numbers in mind because I'll come back to them later in the talk. In the 1980s, change was in the air. In the lab, new technologies, new techniques, and cancer models began to be used to unmask some of the fundamental biological and molecular changes in cancer cells, which foreshadowed opportunities for new treatments, which would come along in the subsequent decades. In the clinic, Canada, like many other countries, started to think about collaborative clinical trials networks as a means to conduct large sample size clinical trials rapidly to address questions to improve care. In 1980, with funds from the Canadian Cancer Society, the National Cancer Institute launched a clinical trials group called the NCIC-CTG to coordinate and conduct cooperative clinical trials to improve cancer outcomes. Cancer centers across Canada joined, including the centers here in Saskatoon and Regina. And the inaugural director of the NCIC-CTG was an oncologist named Dr. Joseph Pater, who was based at Queen's. And much to the chagrin of the Torontonians on the search committee, he said, I don't see why I need to move to Toronto to do this work. So the NCIC-CTG was set up as a research unit at Queen's University to run this national network. Now, the mission of the cooperative trials group was to develop and conduct trials aimed at improving the treatment and eventually the prevention of cancer with the goal of reducing morbidity and mortality. And to do this, we required 3 interlocking components. Firstly, scientific and clinical leaders needed to be engaged to come up with the best questions to address through clinical trials. Cancer centers and hospitals had to agree to become part of the network and support the recruitment of patients into those studies. And there needed to be a central statistical and coordination center, which was based at Queen's University, and all these worked together to produce the comprehensive clinical trials group. In 2016, the NCIC-CTG was renamed the Canadian Cancer Trials Group to reflect more accurately what it did and where it was. And I will refer to the group and its work interchangeably over the course of this talk, mainly because I get confused sometimes. So let's talk about the investigational new drug program, which is where I joined the story. A little backstory here. In the 1970s and 80s, most new cancer drugs were developed, as I mentioned earlier, through the US National Cancer Institute. Perhaps laughably today, it was important to note that pharmaceutical firms weren't interested in cancer as a place to develop drugs because it was too risky, often didn't work, and they would lose money. It would be a money-losing area to invest in. In 1981, the NCIC-CTG decided to establish an investigational new drug committee, which was chaired by a University of Manitoba clinician named Brian Weinerman. And the reason for this was we were finding we were a little late out of the gate to get our hands on drugs coming from the USNCI just because we didn't know what was going on in time to be competitive. So their recommendation was to create a program, appoint an oncologist to run the program based at Queen's, and that person's role would be to connect with the USNCI, learn about the drugs coming through the pipeline, and support Canadian investigators being able to study these agents through a letter of intent process. So in 1982, the investigational new drug program was founded, and I, in my big shoulder pads, there we are in the 80s, joined the group. Intended to be a 2 to 3 year appointment, but of course, things change as you get used to something, and I was there well over 30 years. Let's remind ourselves what 1982 was like for a minute. Probably most of you weren't born then. This guy named Michael Jackson released an album called Thriller. The Canadian Constitution was repatriated. The desktop computer was Machine of the Year. This new strange autoimmune syndrome called acquired immunodeficiency syndrome was first described. And this, well, strange guy from New York City in the bottom left there started to become a real estate magnate. And oh my goodness, if we only knew now what was going to happen, or knew then what was going to happen. In my personal life, I had a 3-month-old daughter, Nicole, and a 2-year-old Danielle. And I'm happy to say that Danielle is here today listening. So in the early years of this program, I decided it made sense to focus on so-called phase 2 studies, which are fairly straightforward trials designed to screen promising new drugs for any evidence of activity in patients with a specific tumor type. Despite the fact that oncogenes were first discovered in the 70s, and that would mean a lot for future clinical trials research, most new drugs continued to be cytotoxic agents coming from the USNCI. And of course, we had a few lemons in the first few years of the program, but also some other exciting results. And here are a couple. The first of these is IND-12, which was a phase 2 study of a drug called CBDCA, which later became known as carboplatin, one of the first studies of carboplatin in ovarian cancer, and the first in Canada, where we saw that the drug was active in recurrent disease. And as those of you involved in the clinic know, it's now a mainstay of frontline treatment in ovary. And another drug called deoxycofamicin, which emerged from the research lab studies of a hematologist named James Johnson in Winnipeg. And he studied this odd leukemia whose malignant cells look, as described, look very hairy, and found that this worked in the lab. So we worked with him to develop the package for Health Canada and started a pan-Canadian study, which showed that 100% of patients responded to this treatment, 90% having had complete remissions. So that was pretty exciting. And even more exciting was that I put the very first patient on this trial. I was split my time between the research group and my clinical practice. And this gentleman was referred to me and having a massive spleen filling his left upper quadrant and left abdomen with a newly diagnosed hairy cell leukemia. And we enrolled him on this DCF study. And after just 3 weekly doses, he had a dramatic response with a normal size spleen, normal bone marrow, normal blood work. And he went on 10 years like that. I can say there's actually nothing more exciting than participating in research that has this kind of dramatic impact on a patient's life. So let's move to the 90s. I call this the taxane decade. Taxol, which was the initial generic name of this drug, later generically paclitaxel, was an extract from the bark of the western yew collected by the US Department of Agriculture as part of their relationship with the US NCI, looking for plant and tree extracts that might be active in cancer. And it was put through the screens of the NCI in the 1960s, found to be active, but it wasn't until Susan Horowitz in the 1970s showed that this drug had a novel mechanism of action. It caused stabilization of microtubules, freezing cells mid-division, which caused sort of catastrophic apoptosis, that it then became of interest to study clinically. And the early trials revealed significant cardiotoxicity, severe hypersensitivity type reactions presumed to be related to the formulation of this in Crema-4, but they also showed evidence of tumor responses in ovary and breast. So there was a real motivation to try to find ways to mitigate these toxic effects to carry on. And pre-medication with antihistamines and steroids and prolonging the infusion and admitting patients to hospital to receive it seemed to help. And that's where Canadian investigators and specifically the IND program came in, because we really felt there was a great opportunity to ask questions about the proper way to administer a new drug like this through a randomized trial. So we made a proposal to do a randomized trial in recurrent ovarian cancer patients, in which we looked at a bifactorial design, randomizing patients to 2 dose levels and also to 2 infusion durations. And we enrolled hundreds of patients along with a number of European colleagues, as you see there, and found that, sort of surprisingly, given what the earlier data had predicted, that it was actually the shorter infusion that was not only more convenient, but safer, less myelosuppression, and also retained activity, and the higher dose was also more effective. And this changed practice, not just in 1993 or 4 when we published this, but up until this day, this remains the way that paclitaxel is delivered. But as important as that, it led to 2 other developments. The first was a pretty obvious one. If this drug is active in recurrent disease, what does it do when it's given in the first line of treatment? And so continuing our collaboration with Europe, this time in a European-led trial that we helped design, we did OV10, an international randomized study of standard of care at that time versus platinum plus paclitaxel. And despite the fact that people who didn't get paclitaxel up front, many of them got it when their disease recurred, there remained to be an improvement in survival of a duration of a median duration of 1 year, that again set a new standard of care for ovarian cancer. The other thing that came of this was we developed a bit of a taste for collaborating with colleagues outside of Canada as a way of increasing the reach of research, but also the speed with which we could do it. And so as an example of this, this is a picture of me and Martine Picard, a colleague from Brussels, who remains a friend to this day, at the first International Ovarian Consensus Conference in Denmark. And this started the Gynecologic Cancer Intergroup, the GCIG, a group, an intergroup of groups, if you will, which now has over 30 cooperative groups from around the world coming together once or twice a year to help design new trials and to collaborate with each other. And this happened to be after kind of a spiffy dinner in Baden-Baden, but it's been a wonderful experience to foster those collaborations across borders and oceans, which, as I said, not only speeds clinical research, but creates lifelong friendships. So the 90s really were the decade when taxanes were everywhere. There were dozens and dozens of trials ongoing in solid tumors and hematologic malignancies. In addition, the first analog of Taxol, docetaxel or Taxotere, started phase 1 trials, and it presented with a theoretical advantage that it wasn't formulated in Crema-4, and it was thought, therefore, it wouldn't produce hypersensitivity reactions, and we wouldn't need to pre-medicate patients. Because we'd been so successful with OV9, we were able to reach out to the company making this, Ronquilin-Croix, and obtain sufficient drug to do 5 phase 2 studies, including one in particular, breast cancer by Maureen Trudeau in Toronto. And by the 10th patient on this study, we'd really observed a couple of extraordinary things. First of all, this was very active in breast cancer. 7 out of the first 10 patients had confirmed partial responses with single agent docetaxel. And almost every single one of them had hypersensitivity reactions, despite the bill of sale that it wouldn't happen. So we modified our protocol, and all the other protocols got modified to give pre-meds, which is how it's given now. And Taxotere went on to become the part of the standard of care of breast cancer after this. So now we move to the late 1990s, and change is really in the air. Targeted drugs are emerging. We started to think differently about trial design and endpoints. And professionally, I had a growing involvement in cancer research and oncology professional organizations. I'm not going to talk about number 3, but I will about number 1 and 2. So let's talk about so-called targeted drugs. I have to point out that all cytotoxic chemotherapy drugs do have molecular targets, but we tend to not think of them as targeted in the same way that this new wave of agents focused on targeting signaling molecules and receptors was bringing through. The cartoon on the right is actually a yeast signaling network. And I'm thinking, if it's that complicated in a yeast, I don't even want to try to find a diagram of a human cell. But these are complicated, interrelated networks that speak to each other to regulate cell division and all other cellular functions. And a number of, especially receptors, were the first wave of things to be targeted with antibodies, small molecules, and sometimes with antisense oligonucleotides. We expected these drugs, because they didn't target DNA and cell division directly, to be less toxic and to turn cancer into a chronic disease like hypertension. So I got invited in 1998 to a meeting in Amsterdam and was asked to speak on something I thought would be of interest to the people developing new drugs there. And I thought, well, why not discuss how this new wave of agents should be changing the kinds of clinical trials we do? And that led to a publication you see there. But in brief, what I said then was that the phase 1 dose-seeking endpoint would no longer need to be toxicity. It would be optimal target inhibition. The phase 2 endpoint to screen drugs for activity, well, targeted drugs were probably going to cause disease stability, not tumor shrinkage. So we needed other measures of tumor stability and randomized designs to assess whether they would be likely to be effective and worth studying further. And finally, biomarkers to select the appropriate patients, and more importantly, tumors in those patients for treatment, were going to be really needed. We needed to make sure that people were expressing the marker that we were targeting. And that was not only important, but it was going to be pretty straightforward and easy. So the IND program in the next 7 or 8 years, targeted drugs were everywhere in our program and across the world. And we did numerous phase 1 and 2 trials. I put down some of the ones on this slide. In bold is the target, and then in normal font are the various inhibitors that we looked at to that in various disease sites. And I have to say, most of those trials were negative, except for a proteasome inhibitor, bortezomib, in hematologic malignancies in mantle cell lymphoma and Waldenstrom's, and sorafenib in acute myeloid leukemia. That said, we also in our group at the CCTG did several phase 3 trials, which were positive for overall survival, including one in colorectal cancer and in non-small cell lung cancer. And both of those were EGFR targeted trials. And both of them led to tissue collections that helped us understand better how to select patients for treatment. By 2005, I think the view internationally was there was kind of a mixed response to where targeted therapy was getting us. There were some hugely game-changing and striking improvements in outcomes, such as the use of imatinib in CML. This agent was also active in GI stromal tumors, a rare type of sarcoma. That's the survival curve. And there were some less visually dramatic, but nevertheless important and practice-changing studies, such as the one of the HER2 inhibitor trastuzumab, given as an adjuvant to HER2-positive breast cancer patients. Some were negative, such as this EGFR inhibitor versus placebo in non-small cell lung cancer, and some were even worse than negative, where a MET inhibitor added to erlotinib in non-small cell lung cancer actually worsened survival. So the bloom on the rose of targeted therapy was fading slightly about 20 years ago, and realism was setting in to some degree. Not everything was going to be in imatinib. And interestingly, my predictions from 1998 were pretty well absolutely wrong. Targeted drugs were toxic, just different toxicities than we were used to. And dosing based on target inhibition, while a nice ideal, was extremely challenging to do. Taking little bits of skin and hair follicles and tumor and measuring target and downstream effects, extremely complicated to do and hard to nail down a dose when people had a lot of heterogeneity. So toxicity really did still drive dosing. Finally, and sort of gratifyingly, targeted drugs did cause tumors to shrink. If you turn on the signaling pathway that's driving the cell to kind of grow and divide, sometimes they died. And so a fellow of mine, Rob El-Miraghi, and I actually looked at a whole swath of targeted agents and looked at what could predict success in phase 3. And it turned out that the strongest predictor we found was the rate at which patients had responses in phase 2. So a drug that had response rates of 30% in phase 2, pretty well guaranteed to improve survival in phase 3. One that had a 5% response rate almost never improved survival. So, and finally, biomarkers were important, but they were not easy. And sometimes what we thought was the marker to select a patient, like the expression level of a receptor, turned out not to be important. It was whether that receptor was mutated, for example. And this was kind of humbling. And I think as scientists, we know that what you think will happen when you do something in human beings based on your up to that point knowledge from laboratory models and systems may be wrong. And you need to be open-minded and focus on the effects seen in clinical trials to really understand where to go next. So moving ahead to the next few years, we still saw numerous new targets being defined and drugs being developed against them. The genomic revolution was underway, and the rise of the precision medicine mantra, this idea that knowing which were the genetic changes in a tumor might perhaps allow you to kind of pick the right drugs off the shelf, combine them, and treat that particular tumor. But in addition, anti-angiogenesis drugs were emerging as a sort of a whole new way to think about cancer. Instead of thinking about the cell, you thought about what was supporting its growth. And professionally, I was moving more from the cancer research activities I had into the Canadian Strategy for Cancer Control and policy work. But let's just talk about anti-angiogenesis therapies. So Judah Folkman, I think widely regarded as the grandfather of this area of research. He was one of the first to describe the role of new blood vessel formation or angiogenesis in promoting and sustaining tumor growth in animal models, and also in identifying inhibitors of this process. And on the right, you see a murine experiment of tumor volume, where you have on the top line untreated, in the bottom line angiogenesis treated animals. So the expectations in the clinical cancer research community were very high when one of the first of these drugs, endostatin, went into clinical trials, that cure was finally in sight. And we, in the IND program, did several phase 1 and 2 studies, notably one with a small molecule angiogenesis inhibitor, cediranib, and developed combination regimens going then into randomized lung and ovary trials The lung study was completely negative, as were other studies of angiogenesis in that disease. But the ovary study was kind of slightly encouraging in that progression-free survival improved, but unfortunately overall survival, although it looks as though it's better on this graphic, was not statistically significantly better. Over the next few years, the wave of angiogenesis inhibitor trials was sort of unprecedented. At one point, there were more than 1,000 clinical trials ongoing of the VEGF inhibitor bevacizumab alone. And despite all these studies, angiogenesis inhibitors have only rarely had a meaningful impact on cancer survival. And I think there are a couple of reasons for that. Firstly, preclinical models, like the ones Dr. Folkman was using, which tend to rely on fairly rapid murine tumor growth, because you don't want to wait 6 months to see if a drug works in a mouse. You're looking for tumors that actually double every couple of days. That kind of model shown here, here's a transplantable mouse tumor with a half-life of growth of, or doubling time of 2.5 days, and compare that to human breast cancer. Again, these are in Petri dishes, but the tumor doubling time of 3 months. Not surprisingly, that those murine tumors were exquisitely sensitive to being able to generate new vessels to support growth, whereas the human breast cancer might have had workarounds. So the models we use can sometimes mislead us. But in addition, it was interesting to me how people kept throwing more and more research into an area that wasn't proving itself. And when a drug or a drug class has limited activities, you can't make it into something that works better by just doing thousands of trials. So where are we going today? We are in, I think it's fair to say, a revolution of immune oncology. Professionally, I moved from my job at the clinical trials group into university leadership, and I got more interested in cancer prevention and palliation. But what I'm going to focus on here is also how I am starting to rethink again trial endpoints and design, and then give you a little bit of an update of where we are with outcomes. So let's talk just very briefly about immune oncology. If angiogenesis inhibitors were a wave, this is a tsunami. The checkpoint inhibitors CTLA-4 and PD-1, PD-L1 really were the first that showed that finally, after decades of work looking at approaches to an immune system change that might cause tumors to regress, have finally borne fruit. These have been transformative in melanoma and have activities in many other tumors. In addition, cell-based therapies, including CAR T cells and other T cell manipulation, have been shown to be active in hematologic malignancies, and there are many trials ongoing in solid tumors. And in fact, this from a publication this year of Nature Reviews of Drug Discovery shows in each bar of this graph the number of trials begun that year of the various immune therapy modalities. And the checkpoint inhibitors are the dark blue line at the right. And you can see in 2022, there were over 2,000 new trials started that year of various immune therapy activities. Hard to believe there were 2,000 unique questions. I am sure that a lot of these are duplicative, which is sad in a way, because you're using up precious patient resources with every trial you do. At the CCTG, we have done or have ongoing more than 20 clinical trials in this space, including an adjuvant lung cancer trial, which I helped to design when I was still there, a melanoma trial looking at optimal duration of treatment, as well as combination and translational studies. And most recently, Annette Hay, who's one of the clinician scientists at CCTG and head of our hematology division at Queen's, has got funding to set up a national CAR T production platform so that we can produce CAR T cells for clinical trials. So let's circle back to this endpoints thing that I kept perseverating on through my story. And I'm calling this trial endpoint regression. I did tell you that the predictions I made about targeted drugs and their designs were largely proven false, but nonetheless, the primary endpoints used in many randomized phase 3 cancer trials have shifted from overall survival to progression-free survival, which is a measure of time to tumor growth, mostly on imaging studies. And sadly, that measure is only rarely a surrogate for overall survival. Here's a paper that we published a couple of years ago looking at the trends over time in the endpoints that were being used in cancer trials. And as you can see, the orange line on the bottom, progression-free survival, has really now surpassed overall survival in terms of the proportion of trials, randomized phase 3 trials that use this as the endpoint. And you can see industry funding has also grown in a commensurate way. And there are lots of reasons given for this, but however you want to play it out, it seems we are asking less of a new drug in terms of the potential for impact if all we're doing is looking at imaging changes. And they are costing way more, hundreds of thousands of dollars, sometimes a month to give. And beyond that, if we're using this to decide which treatments we should be offering patients, we have to ask ourselves, has anyone ever asked a patient whether delaying the time to tumor growth means anything to them? We couldn't find that they really had, so we thought, great grant idea. Do patients think increasing progression-free survival to be meaningful? And we got CHR funding to do this multi-center study where we asked 100 patients who were on palliative chemotherapy or systemic therapy with metastatic cancer that question. And we designed this in a sort of a trade-off experimental way. Patients first had to be educated about what PFS meant. Because honestly, if you tell someone this increases progression-free survival, you can bet people are going to hear that last word and they won't really know what it means. Well, when you explain it means that tumors grow 20% on imaging, it doesn't really fit with what the words say, does it? And then we asked the patients what kind of increase in that measurement would lead them to take a new treatment that had some toxicity, but no effect on how long you actually lived, which many of these drugs are showing. And like many of these other experiments, 17% that they would take the treatment for no benefit at all. This is quite common in these kinds of experiments. About a quarter would take it for some benefit, anywhere ranging from 3 to 9 months gain. But just over half would decline the treatment no matter how much progression-free survival increased if it wasn't going to affect how long they lived. So I think it's fair to say that prolonged control of tumor size on imaging is not universally valued by patients, and yet it is now the most common endpoint we use in trials. And this was just published like a couple of weeks ago in JNCI. And this has led to kind of a new initiative that I have been privileged to be part of. As you say, retirement is never boring, at least in my way, retiring. And this initiative called Common Sense Oncology was born of this increasing concern amongst clinical research and patients that there's a bit of a paradox in cancer medicine today. On the one hand, there's a substantial overutilization of marginally effective, toxic, and expensive medicines, especially near the end of life. But at the same time, due to problems of access and affordability, many patients in our world do not get the cancer medicines which make a big difference in outcomes. And doctors Chris Booth and Bishal Gayawali, both at Queen's, hosted an international workshop of patients, researchers, and clinicians from 15 countries in April of this year to talk about, well, what can we do about it? What can the community do to change the way we're thinking? And out of that workshop, Common Sense Oncology Outcomes That Matter was born. And about 4 weeks afterwards, in Lancet Oncology, an opinion piece was published. And you can see by the names of the authors here that this really represents people from various different backgrounds and countries. And the mission of this initiative is to ensure that cancer care focuses on outcomes that matter to patients. And one element of the vision, there's a longer list in the paper, is that patients have access to treatments that provide meaningful improvements in the outcomes that matter to them, irrespective of where they live or their health system. And there are 3 pillars of work ongoing around evidence generation, evidence interpretation, and evidence communication, which you can see here. And each of these working groups is a little international group with a couple of patients also involved or co-chairing the work. And we've launched a website, which I show here, where we invited people the same day the paper was published to join in if they were interested. And within 2 months, we have 1,000 people from around the world signed up. Hard to know how we're going to harness that energy, but patients, regulators, pharmaceutical firm researchers, clinical researchers, policymakers, every walk of life. So let's sort of backtrack and say, well, that's what we're thinking about now, but what have we actually achieved in the last 35 years? We being the cancer clinical research community or the cancer research community. Our 5-year net survival overall now is around 64% for all tumors, compared to around 50% in 1980 and 33% in 1947. And the net survival has also improved. I contrast here those original 1987 data with 2021 data. These are from the Canadian Cancer Statistics. And you see now that there have been quite dramatic improvements in 5-year net survival, whether through treatment or early detection and screening programs, with the exception perhaps of lung cancer, a fairly big relative increase, but still an absolute outcome that needs a lot of improvement. And in my 35 years, this is kind of what I've seen. The era of cytotoxics huge at the beginning, tapering off, but still not gone. Targeted drugs and precision medicine rising, and waves of taxanes, angiogenesis inhibitors, and we're at the beginning of the immune therapy era. And interestingly, this corresponds with how we've been thinking about interfering with cancer. So in the 1980s, we were thinking about how to affect DNA in the machinery of cell division. We then thought, let's think outside the nucleus into cell signaling. Then the tumor microenvironment where angiogenesis came in, and now whole organism, whole person kinds of treatments based on immune oncology agents, cell therapies, and microbiome. The Canadian Cancer Trials Group is now 85 centers across Canada. The director today is Dr. Janet Dancy. Ralph Meyer followed Joe Pater, and I was interim director for a little while we recruited Janet. We have many international partners, 2,100 investigators across the country involved, from clinicians to pathologists to basic scientists, and 4,000 staff in all of these cancer centers and hospitals who participate in enrolling patients on trials. So what's coming next? I think it's fair to say cancer biology and discovery research will continue to unveil new opportunities for therapy, and the scientists involved in sort of medicinal chemistry and pharmaceuticals are really starting to drug what we used to consider completely undruggable targets, such as RAS and P53. We're starting to see, as I said, the impact of immune oncology, and I think this is just beginning. I didn't mention antibody drug conjugates, but this is another big area of research and development. And we're measuring free circulating tumor DNA in blood with greater facility. And that gives us opportunity, perhaps, around earlier diagnosis, monitoring of treatment and relapse and mortality. But all of those kinds of questions still require randomized studies to see if we do make those impacts. And everyone knows that we have a lot of faith in the mountain of data from patients, biospecimens, imaging, and various omics being harnessed to develop better predictive and prognostic indicators and to design new treatments. So my advice, I'm always giving advice, even if I'm not asked, to the next generation, my daughter knows this, next generation of clinical cancer researchers is be collaborative. Let's get there faster together. and resist the push to endlessly duplicate ongoing research just so you can say you have a trial doing something. That's so wasteful. Use endpoints that are meaningful to patients, and importantly, I didn't get a chance to really expound on this, engaging patients as partners, not just subjects of research, but partners in the design, oversight, and the priority setting in research. If there are any cancer research funding agencies around, I would like to say, invest in academic clinical research, create the infrastructure in Canada for a healthy clinical trials community, not just in cancer, but more broadly, so we can conduct trials beyond the interest or the narrow interest sometimes of pharma into areas of importance to clinicians and patients and policymakers. So lots of thanks over the last 40 years, particularly the Canadian Cancer Society, which has continued to provide core support to the Canadian Cancer Trials Group for more than 40 years now, and as well as research grants and infrastructure grants from the other agencies shown there. And to all of the mentors and colleagues and trainees and thousands of patient volunteers that I've worked with over the years. I also like to say lots changed since those two little babies were on my sofa. My daughters are both now well into their own careers, one with a PhD in public health, the other a palliative care physician. My husband and I have grown grayer and older, although I have a way of dealing with that. And I have two beautiful little grandchildren shown there, Gabriel and Tess. So much has changed since 1982. I hope you get a sense from this of the times I've been privileged to live and work in. And in addition to living through this time and seeing those big impacts on cancer outcomes, some of which were related to the trials I was doing with the CCTG, my personal journey was never really planned or expected, and it has brought lifelong friendships and fantastic shared experience, and importantly, meaning. This has been a highly meaningful thing as a way to spend my professional career. Our work is far from done. Too many people are still developing, suffering with, and dying of cancer. And I close with the Robert Frost phrase, we have promises to keep and miles to go before we sleep. So thank you very much for your attention.
Thanks very much, Elizabeth. A wonderful tour de force, taking us through the years of cancer research. Maybe we'll start from the questions from this room, and then if the colleagues online could put the questions on chat, I will relay these questions to Dr. Eisenhauer. So, any questions from the room? Maybe yes, please.
I wonder if there's a result that you were the most
Oh, that's tough. Well, very early on, that deoxycofamicin result just blew the socks off of all of us. I mean, 100% response rate is pretty rare in cancer clinical trials. The paclitaxel result, I don't think we really expected there to be as much of an impact of shortening the infusion on safety in patients. It was hard to see from the results. One of the studies I did in glioblastoma, collaborating with our European partners, was one which improved survival, the first clinical trial to improve survival in more than 35 years of various studies. And so that was surprising, because when you do trial after trial after trial in a disease and they're all negative, the prediction you would make of any subsequent trial is it would also be negative. So that was also surprising. I think some of the results, that wasn't my personal research, but clinical trials group work of some of the early EGFR inhibitors, which we studied in fairly unselected populations, and it showed a survival advantage. But then when we got the tissue and were able to analyze it, we were able to show that in the case of the lung cancer trial, that it was only patients who had a mutated receptor that were benefiting. And that fit with results now coming out of the States. And if you look then at the survival curves of people who had a mutation, and got treatment or not. It was a much bigger impact. And the same in the colorectal cancer study. Strangely, that was an EGFR inhibitor, but it was nothing to do with EGFR who benefited. It was whether they had a RAS mutation. If they had a RAS mutation, they didn't benefit at all from upstream EGFR inhibition. But if they had wild type RAS, it had a big impact. So I don't know, there were probably others, but those are the top of mind.
Thank you. I was about to ask, my question is that I am actually nanopharmacologist, and one of the nanopharmacology, nanomedicine interests is the selective drug delivery platforms based on nanoparticles. And we had some examples over the years with liposomes, which were the first guys on the block, then the albumin nanoparticles. What's your view on the selective drug delivery system? Any useful? Are they any useful? Is it the prospective good direction of research or not?
Well, I think what started out being, I'm not an expert in this area, but my reading and work over the years suggested that the initial thought about packaging the drugs in a way that they were preferentially taken up into tumors was not a bad idea, but a better way of doing that is to make an antibody drug conjugate. And that way you get the antibody to take the payload to the tumor, and then the toxin's released and has an effect. And there are already drugs, especially in breast cancer.
And you can hybrid both of them.
Yeah, and that's a big area of research and work. The key, of course, is to find the antigen or the protein that you're going to target that is fairly uniquely expressed on the tumor. Otherwise, you're packaging up the drug and delivering it to all sorts of different organs, wherever that antibody might land.
Yes, please, Anand.
So I understand that like most of these candidates, like the participants that contribute to the trials, they were mostly in advanced form of disease. They were carrying like stage 4 cancer or so. So in such case, when we try a new targeted therapy, there is less likely that it will be very effective because they have like already the cancer progressed to severe stage. So what is the missing trends in?
So it wasn't always the case that we did that. For example, remember I said in the Taxotere or docetaxel trial, we saw 7 out of 10 responses. We enrolled women with metastatic cancer who had had no prior treatment for their metastatic disease in that trial. But it is true that the drug development paradigm most often used by, especially by pharma, is to look at people who've exhausted all of the therapy and then offer the new drug. And that's giving it a pretty challenging road to show that there might be an effect. On the other hand, if there is an effect there, it makes a great case for moving it earlier. But it kind of depends on the setting and what else is available and how good the other treatments are. You're not going to withhold a potentially curative treatment to give somebody an experimental treatment. But you might say, let's give you the experimental treatment if the best standard of care is only a 10% response rate. So there's a lot of individualization or tailoring of the population that you want to study in a disease based on what else is available and how effective it is.
Thank you.
Any other questions? I will take again my privilege of a chair. And it's fascinating to learn about the sociology of the progression-free survival. And I've got some unfortunate friends from medical profession whose progress is evaluated by imaging. And I must say that they get excited when the tumor shrinks by 1 millimeter or 2 millimeters. But I think you are right, the remaining part of the patients may not be that mindful. Yeah. Do you think it's a sociological, it's a psychological factor or something else is in play?
Yeah, I think the question we were particularly interested in is how eager would patients be to take a drug that might slow down imaging progression, but have zero impact on survival. And many of the drugs that slow down progression also have an impact on survival. It's just that probably too few of them do. And in that instance, you know, if you're getting a drug that you know has already been shown to improve how long people live, and you see that your tumor is stable or shrinking, that would be psychologically a really important thing to see.
Thank you. And any other questions from my room? I don't see. Oh, well, I've got the Dr. Eisenhauer. It was a pleasure listening to you. A great initiative on common sense oncology. What, in your opinion, on the pragmatic future of microRNA and oligonucleotide-based cancer therapeutics like CpG vaccines in coming years?
I have to plead a little bit of ignorance here. I know some people, given the success of using, I'm assuming it's mRNA in COVID vaccination, has really opened the eyes widely of thinking about this as a way of delivering proteins or other things like that that might have an ameliorative effect on cancers. And I know of some studies of that going on. I think it's like anything else. You can't predict. You have to do some great preclinical science and take the best ideas into the clinic and test them.
Thank you very much. Any other questions coming
I don't see any online.
From our online? If not, will you join me in thanking Dr. Eisenhauer for a wonderful presentation, and not only for 35 years of clinical trials.
Thank you.
Thank you, Elisa.
Thanks very much.